You're watching Your Bones Matter by Dr. Alyssa Gall on Resonance Wellness TV, part of our Whole Life Medicine Alleviate series. Keep in the loop about future webinars and events on whole-life-medicine.com. Hello and welcome to this webinar on Your Bones Matter. My name is Dr. Alyssa Gall and I'll be your guide this evening about all things skeletal. And as usual, this presentation is given in the context of the whole life medicine model. That's the model that I use at Resonance when I'm evaluating your healthcare situation. And so when we talk about bone health, we're talking about all the aspects of alleviate. So we would do a root cause review of the aspects of health that have an impact on bone today. We're going to look at what toxins might pose a risk in bone health and look at potential missing ingredients in the normal maintenance of bone. And once again, you're going to see some common factors crop up today that we have discussed in the context of many health issues. I'm sure some of them you're just going to get sick to death of me repeating, but hopefully not. Hopefully you're just going to incorporate all the ideas. So let's start by looking at some basic facts about bone. Bones are living, active tissues, and they're constantly being remodeled. And I thought you might be interested in seeing some contrasts in bone at different ages. So at birth, like we're seeing here on the left-hand side, the skeleton is actually only partially formed. There are still tissues in between these little baby bones, but they're all cartilaginous, just like they are in the skull. So the ends and the shafts of the bone in a child grow separately, and that cartilaginous structure will slowly be replaced by bone as the child grows into an adult. There's about 270 of the soft bone pieces. The adult human body will eventually average about 206 bones. So I say average because not everybody has exactly the same number of bones all the time. Sometimes congenitally, you will find that some don't form exactly the way that the average one does. And sometimes people have a little extra bone here or there. But to just kind of give you a sense of complexity, there's about 26 bones on average in each foot and about 54 in each hand and wrist. So here you can contrast what a baby arm looks like with the arm of an adult. So that's just that one that's in the middle. And so bones will stop growing in length as puberty comes to a close, usually by about the early 20s. Most males have a longer period of bone growth and their skeletons are bigger overall. And the clavicle or the collarbone doesn't actually finish growing until you're about age 25. And that's probably why the collarbone is the most commonly broken bone amongst children. In adults, the most commonly broken bone is in the arm. But once you reach 30 years of age, you're going to achieve something that's called peak bone mass. So bone density and strength can change over the course of life, both on the uptake and on downstream. But usually you'll have the most mass developed by the time you're about 30. And as the years pass, certain types of bones actually are going to lose mass that you're not even realizing are losing mass. So I thought you would get a kick out of seeing the changes between a young female adult skull and an older female adult skull. So you can see here that as the years are passing, facial bones can lose volume. So this contributes to the appearance of aging. And here the CT images are showing a skull that's clearly under the age of 40 and the skull of a woman over 65. So the bones of the older female are showing that the eye socket is larger. The angle of the lower jaw bone has dropped quite a bit, and the angle of the brow is also reduced. So I'm hoping you can kind of get a sense of that. It's hard to see it entirely without skin on it, but it's really an interesting set of images that remind us that not everything is static, and it's not just the skin that's changing as we get older. Now, bone is a unique type of tissue in the body because it's calcified organic tissue. So bones are a mix of organic materials and inorganic materials. And 30% of your bone is actually an organic protein matrix. 60% is calcium phosphate crystals and some trace minerals, and the remaining 10% is water. So a lot of your bone volume wise is made out of this specialized collagen protein. And it's a tough fiber wound up braid, like a braid, and it's impregnated with these other proteins and enzymes, cell signaling molecules, and obviously it's impregnated with minerals. So if anybody has asked me about bone health in the office, I might have asked you if you've ever put a chicken bone in vinegar, and I'm going to come back to that whole idea in a minute. If you haven't, you'll see the results. So bones have two kind of types of tissue in them. They have this hard outer layer that's dense and strong and durable, and it's called compact bone or cortical bone. It makes up about 80% of your adult bone mass. And you can see the compact bone clearly all the way down the outer part of the bone shaft on both the picture to the left and the picture in the middle. The second type of bone is called cancellous or spongy bone. And that is consisting of a network of what are called trabeculae, which are rod-like structures. It's lighter, it's less dense, and it's quite a bit more flexible than just compact bone, which is really not that flexible. So that's shown on the upper right here. This is the spongy type of bone. So you're seeing this particular bone dead, though, just so we're clear. I did include a picture on the lower right of bone that is basically like a fresh bone taken out and sliced in half. So there's quite a difference between what we often think of as being bony structures, what we mostly think about is just the mineralized part of it, and what a live bone really looks like. So the entire bone, and you can't really see this very well in this live picture, maybe a little bit, is covered by periosteum. So what that is a tough, fibrous connective tissue, which is what your ligaments and tendons actually attach to. So it's, like I said, hard to visualize here, but it's the stuff that you've pulled on too hard when you get shin splints. So if you yank on the periosteum, it's kind of like a piece of like fascia. If you've ever recognized that there's fascia planes, like in like cuts of meat, people are familiar with fascial planes. It's like that tougher tissue in between muscle masses. And so it's like that, but it's super adhered onto your bone by these little tiny fibers. And then the muscle itself is kind of glued onto the actual periosteum. So if you yank on it hard enough, you'll actually rip the periosteum. All those little connective fibers start to come off the bone. And it really hurts a lot. Obviously, if you've ever had shin splints, if you had the Jane Fonda aerobics window of time, then you might remember shin splints. That seems very common for people doing aerobics. So the bone marrow cavity, so you can see that in the dry bone on the left, that there's a substantive space there in the middle of the bone that you don't see in the live bone to the right. So the bone marrow has two types of tissue. It has red and yellow bone marrow. So red bone marrow is where the red blood cells and platelets and white blood cells are created. You're making about 200 billion new blood cells daily from the average of 6 pounds of red marrow that you would find in an adult. It's mostly located in the ends of the bone, so where the spongy bone is when you're an adult. At birth, all of your bone marrow is red, but by the time you get to be about age 7, half of it will have been converted to yellow marrow. And yellow marrow is found only in the long bones. It gets its name from the high concentration of fat cells, which appear yellow in color. So this type of bone marrow can be found surrounded usually by a layer of red bone marrow on either end. And the yellow marrow contains stem cells. So marrow stromal cells is another name for them. And those cells are pluripotent. That means they can produce a number of different tissues, but in this location, they produce cartilage, fat, and bone. So yellow bone marrow also stores fat in adipocytes. So just like any other fat storage place in your body, you also store fat in bone. And it's basically going to help maintain the right environment inside the bone and helps you to provide some nutrients that you're going to need for the bones to function. So really, in a way, the bone is like its own self-contained organ. And again, we don't typically think of it like this. We don't think of them live. We think of them as like being the Halloween bone structures that are brittle and break. But you can see there's much more to it than that. Much, much more. Now, bones are constantly being remodeled. Like I mentioned earlier, they're really not static structures. So about 10% of your skeleton is replaced every year. And there's a process called remodeling, and that is allowing your body to fix damaged sections of bone. It helps reshape the skeleton during growth because the sizes and shapes of the bones have to obviously change radically. And it's part of how you regulate your calcium and phosphate levels. And so pH in the blood is actually in part maintained by drawing on bone mineral storage. So there's three types of bone cells in general. There's some accessory cells too, but the main ones are osteoblasts, osteoclasts, and osteocytes. So osteoclasts, I always think of the names clast. Kind of C looks like a Pac-Man to me. This is how I remembered it in medical school. C looks like a Pac-Man to me. So an osteoclast is a big cell. It actually has more than one nucleus. It's a big polynucleate cell. And the job of the osteoclast is to break down bone. So these kinds of cells release enzymes and acids. This is dissolving the minerals in bone and then digesting them over about a 3 to 4 week period. So this is actually called resorption of bone. And then the osteoclasts are basically taking out injured pieces of bone. And they also are responsible helping create pathways for nerves and blood vessels to get into the bone to travel through as people are growing. Now we can see that I've got this diagram and it's marked in blue here. So big cells breaking down bone from the damaged bone. And then there's osteoblasts. And B, I'm in medical school, I thought B stands for build. So Pac-Mans and builders. And so the osteoblasts are responsible for making the new bone. And so that basically repairs older bone. So osteoblasts produce a protein called osteoid. So that's the mix of all of those pieces of collagen structure. And then that structure becomes mineralized and becomes bone over 3 to 4 months. So it takes substantially longer to put the osteoid down and then mineralize it. So the osteoblasts are also manufacturing hormones, including pro and anti-inflammatory hormones. And then there's a category called osteocytes, and you don't really see those on this particular diagram that I'm using here, but osteocytes are basically what happens to osteoblasts over time that become trapped in the bone that they've actually created. So they don't die though. They actually stay in the bone and they maintain the connections to other osteocytes like themselves and to osteoblasts. So they're super important for communication within the bone tissue. And so it's kind of like having a nervous system within the bone. And they have these long branches that connect to the other osteocytes. So they can actually sense pressure or cracks in the bone. They can help to direct where the osteoclasts and osteoblasts are going to remodel things. And their average half-life is 25 years. So even though they were produced and are basically sitting trapped in the bone, they'll continue to live and function for a very long time. One of the longest lived types of cells in the body, other than nervous system cells. So you can get a lot of metabolic activity in a bone, and there's lots of different hormones that are being involved here. And we're going to talk about hormones later on in the lecture, but just so you have a sense, you're constantly got this amazing life-filled structure that just happens to be mineralized. I think we have to kind of reverse our thinking about it. So in addition to supporting the frame of your body and then protecting internal organs like your ribs do, as an example, bones also have several metabolic functions. So, like I said before, they act as a reserve for minerals, especially calcium and phosphorus. So those two minerals are the basis of two of the three main pH buffering systems in your body. So bones can raise or reduce calcium or phosphorus by forming the bone or breaking it down. And so there are signals that will change pH by increasing bone breakdown or increasing bone building. I think that's really interesting and something to really note. And those minerals are playing not just roles in bone, but multiple roles in muscle and nerve function. They're cofactors in the metabolism. There's lots of places where you're going to need calcium and phosphorus. Bones also store some growth factors, like insulin-like growth factor, and you may have heard of that in passing with inflammatory syndromes or with cancerous issues. They're major signaling molecules. Fatty acids are stored in the yellow bone marrow, as we discussed, and they can also absorb heavy metals and other toxic elements from the blood. So you can store them in the bone, and it decreases the effect on the day-to-day metabolic functions, but that's probably going to come at a cost to turnover. And there's some toxins that are quite marked on bone. Lead would be one of them. It's also recently been discovered that bones really do function as an endocrine organ. So endocrine organ means that it's secreting hormones of its own. So obviously bones release something called osteocalcin. It's involved in bone maintenance, but it also influences blood sugar regulation and the way that fat is deposited around the body. So there's quite a few other molecules that are coming from the skeleton that are being investigated in energy metabolism and control of growth. And this is quite an expansion over the previous thoughts about what bones really do. And to give you a sense, I mean, this is recent, like in the last 10 years, probably even less. And so it's kind of an exciting new area of research because old assumptions about tissues that everybody thought they knew what was happening in there are really being revised. So now that we have some bone anatomy and physiology out of the way, we're going to talk about how we are going to keep bones healthy. So let's start with a summary of factors that are involved in bone turnover. So obviously the health of bone has a lot to do with how efficient and how balanced bone turnover is. Because remember, I said that osteoclasts can break down a location in 3 to 4 weeks, and it can take you 3 to 4 months to build that back up. So we're going to start with inheritable factors of bone turnover. So it turns out that genetic inheritance is there to some degree with respect to bone and bone strength, but it is not a simple linear type of inheritance. It's really thought at this point that multiple genes need to be present to have an impact on bone in a way that predisposes it to poor health. And that actually is a very good thing because it means that you're much more likely to have epigenetic control over bone turnover. And this actually does turn out to be true. So remember that epigenetics are how your inherited genes are turned on or off. And that's going to result in a different expression of that gene in some function. So in bone health, are definitely epigenetic factors affecting the activity of bone metabolism. And you will remember from other lectures that that often has to do with lifestyle factors. This is how we turn genes on and off. And we're going to see how this has an impact in a moment. We obviously know that diet has a role to play, and there have been attempts to match specific diets to bone health. But what I will say is that once again, I'm going to stick by finding a diet for the individual that has an impact across the board on metabolic function, because obviously all of the metabolism is linked together, including the processes of producing your bones and turning them over. But we're going to just talk about diet in general. So one of the first things that we need to talk about is the maintenance of a healthy weight. And what I mean by maintaining a healthy weight is actually not losing too much weight. Many people don't realize that any weight loss involves bone loss. So yo-yo dieting can be quite harmful to the bones with the repeated loss and regaining of weight. It's quite detrimental to bone health. Eating disorders play a very large role in risk, especially when they've occurred in the times where bone mass is being most substantively built up, which is in the teens to early 20s, when that bone mass was supposed to be accumulating. So that effect is less pronounced in an overweight individual that's experiencing weight loss, but studies have shown that diets that are fewer than 1,000 calories per day can lead to lower bone density in normal weight or overweight individuals. Being underweight in general can be harmful to bone health. The research shows that being underweight in general can increase the risk of osteoporosis. And I say in general because sometimes people are just small framed, and there's a difference between small framed and underweight. So, but it does, if you are particularly restrictive or you've undergone some major weight loss, it can actually contribute to bone loss. And it's particularly going to be notable if those things start to happen around postmenopause, when other factors are starting to play a role, for women at least, in bone density. We'll talk about men a little bit in a moment. So again, generally speaking, there are epigenetic factors that are totally modifiable by dietary components that are going to have really significant impacts on bone density. And there are a couple of molecules that have been researched in recent years that have really shown influences on bone health. And many of these you've already heard about before, again, from other lectures that we've done, where they're not just improving bone health, but they're improving metabolism and functioning in general. So the use of resveratrol, I think it's a little bit unclear, sorry, in this graphic, but that top one is resveratrol. Ferulic and syringic acids, sulforaphane, and anthocyanins from food have really specific advantages. So here you can see on the resveratrol side that resveratrol comes from grape skins or acai berries or peanut skins. There's a number of different foods that have them. So peanut skins, so the brown part, not the actual nut part. But you can see that they've been shown to increase bone formation and reduce bone loss. And that's through a couple of main factors in gene expression and inflammatory control. I'm not going to review all of those things because it's quite a bit more confusing. So, but suffice it to say, they've been shown that to increase bone formation and reduce loss. Ferulic acid is found in many grains, corn, rice, flax, oats, and plants like Angelica sinensis. That's dong quai, and it's a commonly used herb in bone conditions in Chinese medicine. Syringic acid is also found in acai, but it's also found in the shiitake mushroom. And you can see that they're both involving increased bone formation and reduced loss. And this is a different mechanism that's actually like a mini genetic mechanism. So an miRNA is a kind of independent floating around RNA. And again, we don't have enough time to talk about all of the details of that because this is also newer research. There's also sulforaphane. You'll probably have heard of sulforaphane if we've talked together about using broccoli sprout powder. It's a compound that's also high in other cruciferous vegetables. And you can see here, again, same thing. You're increasing bone formation and reducing bone loss. Now, one of the uses for sulforaphane that you might have heard me talk about is the epithelial repair. And epithelial repair, so that really has to do in part with collagen repairs. And so in bone, we've already talked about how bone has a huge component of its collagen. And so you can understand why sulforaphane would be helpful. It's really excellent at repairing DNA as well, which is noted here. Anthocyanins are the colored compounds in plants. So as an example, an increased intake of plums has been shown to improve bone mass density. So have blueberries and black currants. So in the diet, we want to see lots of colored compounds. of all colors. So I'm just mentioning the ones that are dark purple, but you can get anthocyanins across the color spectrum. So eating your 5 colors of vegetables can be very important. Now, I said I'd come back to the chicken bone. And this is actually a picture of the chicken bone that has been soaked in vinegar. And what you can see is it still looks like a bone, still looks like the chicken bone, but it is completely bendy. And so what I'd like to point out about this is that what's really sitting here predominantly is the collagen structures and all the other structures that make up bone, not just the mineralization. So, of course, arguably, this is a chicken bone, and chicken bones are lighter. They're made for flight. And, well, I guess relatively speaking, short flights in chickens. But, and human bones are definitely structured in a larger way, and we don't fly. So we don't have to worry about the bone being too light. But that just gives you a sense of if we could soak your bone in vinegar long enough, it would probably look quite similar. So the kind of collagen that's in your bone is mostly type 1 collagen. So before you go out and eat a bunch of collagen, please remember you cannot absorb collagen whole. You need to break it down and absorb it as amino acids or short chains of amino acids. A type 1 collagen molecule is thousands of units long, and it's in association with multiple fibrils of collagen. They're all wound together. And so, of course, having those amino acids is good, but please don't assume that eating collagen will plant collagen in your bones. I've had lots of questions about this in the last year or two, as there have been quite a few collagen supplements that are out on the market. And I've also seen references to there being, a lot of collagen in bone broth as an example. And there's definitely some, but it's really about, can you take those nutrients, break them down enough to absorb them? Because again, these are such huge molecules. It's kind of like trying to get a semi-trailer truck through the front door. Unless you break it down and bring it in one piece at a time, that ain't happening. So it's also been shown that those foods we spoke about, obviously, like I said, are their factors. They can improve the strength of collagen structures, and that could be at least part of the mechanism as to why they could help bone density. And they do have epigenetic effects to even have those amino acids around. Also, it's been shown that vitamin C really stimulates the production of bone-forming cells and can protect the bone cells from damage. And vitamin C is another major reparative agent for collagen. And so we're going to see this theme in nutrients that are good for bone. It's not like you bring them in and they're deposited into the bone. They're actually part of the physiology of manufacturing the bone. So I want you to think about it from this perspective. I want you to think about getting the right balance. And so I've also heard a lot of conjecture about different kinds of proteins in the diet, or high protein, low protein diets. So protein is essential to bone health. Obviously, collagens are a protein. But in many studies, the impact of how much protein on bone density really hasn't been clear. So the Framingham data, I'm sure we've talked about this before in other webinars. It was a very large study on lifestyle factors that we've discussed in other contexts, showed that a greater protein intake actually benefits bone mineral density and protects against the risk of fracture, as long as those adults have adequate calcium and mineral intake. So calcium intake can modify the association of dietary protein with bone measures. And so that's probably going to explain the lack of having agreeing data in lots of previous studies. So I've seen that there are arguments about not eating so much protein, and that's actually the reason why your bone density is going down. But the data don't actually prove that. So it's about balance. Having enough protein with enough mineralization is clearly more relevant than protein by itself or minerals by themselves. So at the end of the day, we really do have to get the balance right. It's not just about one nutrient at a time. Now, this is a slide of cheese. I just have to laugh because this is not totally the message that I want to send to you. However, calcium is an important mineral for bone health, and it should and usually is consumed daily. There are lots of sources of non-dairy calcium. So dark leafy greens like bok choy or Chinese cabbage or kale, collard greens, turnip greens, they all are excellent sources of calcium. If you just had a cup of cooked turnip greens, so like a cup cooked down, that's like 20% of your daily requirement. So tahini is an awesome source of calcium. So are foods like sardines or canned salmon, if you like those. There's calcium in beans and lentils. You're getting calcium in a lot of different foods. I have heard the concern that people are worried that they don't eat a lot of dairy products and as a consequence, they're not going to have a lot of calcium, but it's just not true. It really started, that whole idea really started when the milk lobby really wanted to sell you a certain number of glasses of milk per year. And so they calculated out the recommended amount based on how much milk they wanted to sell. And that has never culturally quite come undone. And so, yes, there's calcium in dairy products, but there's tons of calcium in lots of things. And along with calcium, you're going to get phosphorus in many foods. It's actually pretty ubiquitous. So nobody really usually supplements calcium or phosphorus. Phosphorus you can pretty much find in anything edible. But there's also a need for other trace minerals like boron, strontium, potassium, magnesium, zinc, all of those things. So if you've had a gallbladder removal, or you're taking drugs that suppress stomach acid, or you already know you have an absorption problem in your gut wall, so say you've got celiac historically, or you have an inflammatory bowel disease, you may do well to top up, especially the most trace minerals. You can see that there are many nutrients that are minerals alongside, like silica as a mineral has been more recognized in recent years as being really important to these bony and collagenous structures, not just bone, but hair and nails, things that are also made from collagens and then slightly mineralized. And other vitamins like vitamin B6, copper, pairs with zinc, like I already mentioned, zinc. They're all related to collagen cross-linking. And then you'll also see, like I said, things that just improve collagen formation, like the vitamin C's and the other antioxidants. You can see the trace mineral manganese being required for bone mineralization. And you can also, of course, see that you need vitamin D for the uptake of calcium. And we're going to talk about that in just a sec. So if you have poor digestion, though, or like low stomach acid or missing gallbladder, all of these really impact these particular components. So is it possible that you don't have enough of the most trace things? Totally. Most people, though, in our culture are not calcium deficient. We just eat a lot, and so the chances of not having enough calcium really start to drop unless you have somebody who's really picky in their diet. Or who is, got a sensitivity or, like I said, some other complex contributing factor. So vitamins D and K have been used supplementally in people with poor bone mineral density, but they're not a panacea. How do you even say that word? I was going to say panacea. It's not panacea. That's what it is, panacea. Sorry, it's late in the day. It was a busy day. And it's not a cure for poor bone health. So the metabolism of vitamin D is really related to the metabolism of light. So that's an aspect of human function that is not often talked about, but basic amounts of it prevent bony deformation from rickets and osteomalacia. That's where you'll see like a true vitamin D deficiency that's body-wide and marked will create bone deformation. So to a degree, its presence does decrease fracture risk, but you're not going to reduce your fracture risk or increase your bone mineral density by loading with it. It's fat soluble, so if you take large doses over a long period, you actually can create problems. And I've been saying that for quite a few years now. And finally, the research is coming out that's saying, yeah, we do have to be careful. People shouldn't be taking so many thousands of units all the time year round. So there really is still disagreement about what constitutes a good vitamin D level. It's really not the easiest lab test to perform either. It's highly, ironically, highly sensitive to light exposure on blood. So if you take a blood sample and the person doesn't slip it into a light-proof sleeve right away, or even while it's being drawn, you'll actually get a lesser vitamin D value. So even in a room of ambient light, you're going to damage it. You're going to damage the vitamin D in the sample. So I sometimes wonder if that's one of the reasons why we see them be so low on average. Well, it's always a consideration. It is important, and vitamin D certainly does other things, but remember that you're a whole unified human being. And so when you have exposure to light as a human, you're actually driving a number of different reactions towards vitamin D. It isn't just one reaction. Certainly, like the UV light has an impact on that last enzyme, but light has a metabolism within you, and it's actually also related to phosphorus. Phosphorus is the light bearer, and you've probably never seen elemental phosphorus, because if you do see elemental phosphorus, it's explosive. That's what's actually in fireworks. So if you have phosphorus as an element, you have to keep it covered in oil to prevent it from reacting with air to produce light. It's just these beautiful metaphors that we have. And you'll see that in people who have an inner darkness, like a depression or a tendency to suffer with like seasonal affective disorder, what that's really showing you is that there's a difficulty in that person's light metabolism. And a lot of the time you'll see that reflected in the vitamin D as well. And as a consequence, you'll see it reflected long-term potentially in bone mineral density. Now, vitamin K helps protein bind to mineral, to calcium specifically. So you get small amounts of vitamin K in things like liver or eggs, fermented foods like cheese or sauerkraut, or the soybean product that's called natto. Not everybody eats that, but it's a common Japanese dietary constituent. And vitamin K is needed in healthy bone metabolism. And a low level, like meaning not having enough, is correlated with a lower bone density. But it is not clearly related to improvements in bone mineral density if you supplement it. Again, this is one of these kind of like ironic double-edged swords. It's like if you don't have enough, you can tell in the bones. But if you overdose on it, it doesn't drive the reactions because they're all so unified. So it is possible, though, that vitamin K improves some of the architecture of bone when it's supplemented. So potentially it might make it a bit stronger, but not more dense. Vitamin K is actively produced by your microbiome. So if your guts are healthy, it's really essential in the stimulation of bone. So antibiotic use in mouse studies will show that there's interference in normal bone building if you have terminated bacterial action. So if you use the antibiotics and kill off a bunch of bacteria, all of a sudden you're going to see an interference in bone production. So again, we circle back to this very holistic, one thing is dependent on the next thing sort of activity. Nice, beautiful, big circles and cycles. Now, I said I was going to talk a little bit about toxins, and these are two very obvious toxins. We've talked about these toxins in many other contexts because they obviously have impacts on other structures besides just bone. But a research synopsis by two researchers named Sani and Keel actually states that cigarette smoking, both how much you smoke and how long you've smoked, is associated with lower bone mineral density and increased bone loss in older men and women particularly. So limited studies have examined if that effect of smoking on bone can be reversible. And smoking effects on bone may not be limited just to the density, but it can also extend to other aspects of bone strength and the bone architecture and the bone geometry. So that means basically how it's being built and how close to the normal patterns it's being built. But it's an area at this point that is not quite receiving as much attention. It's really only become more evident in recent years that bone actually does have more than just the very basic bone unit structure. There's quite a bit more to it than that. And as imaging gets better and dissection gets better, some of these things are becoming more clear. A history of smoking really does result in a fracture risk that's substantially greater than just explained by the risk of lower density. So it's having other effects. Again, it's a major oxidant, so it's going to damage collagen structures. So here we again see, there's a balance between destruction and building and the development of collagen. Alcohol actually seems to have a positive effect on bone density up until about 2 drinks per day. After this, it seems to decrease it. So I think we've seen this repetitively in our exams of quite a few different conditions. Higher alcohol intake does increase fracture risk, but surprisingly, it has to be quite a bit higher, as in meaning like somebody is really addicted to alcohol and it's probably taking in like way more than the average. So there you go. I still have my moratorium on wine has not yet been broken. Okay, now the use of pharmaceuticals also can have a very big impact on bone health. And these are common things. So to quote one reference, and I just quoted it because, this is not necessarily my expert area, but this was the reference. Drug-induced osteoporosis is a significant health problem, and many physicians are unaware that many commonly prescribed medications contribute to significant bone loss and fracture. In addition to glucocorticoids, proton pump inhibitors, selective serotonin reuptake inhibitors, thiazides, anticonvulsants, the Depo-Provera shot, aromatase inhibitors, androgen deprivation therapy like spironolactone, heparin, which is an anti-clotting agent, calcineurin inhibitors, which are often used in skin conditions, and some chemotherapies have deleterious effects on bone health. And they said that furthermore, many patients are treated with combinations of these medications, possibly compounding the harmful effects of these drugs. Increasing physician awareness of these side effects will allow for monitoring of bone health and therapeutic interventions to prevent or treat drug-induced osteoporosis. Now, I just gave you some of the most commonly used drugs on the planet. And in combination, so glucocorticoids are things like prednisone, steroid creams. Most of those things are used topically, and they're not going to have as big of an issue, if you're using that topically for something that you've got going on your skin. But if you've had a period of time where you've had to use higher dose glucocorticoids or prednisones or steroids of any other type, asthma inhalers, those sorts of things, you do have an impact on your bone density. And I think most of the time we, again, don't take those things into consideration conventionally, or sometimes, even naturopathically when we're looking at somebody's bone loss picture. But that's really important. So if you know that you've taken those things, you're going to want to mention that to your primary care doctor. If you have me as your primary care, you don't forget to remind me too, because it is definitely a factor in bone health, amongst other things, of course. Now, strength training and weight-bearing exercise are really essential for bone health. One of the best types of activity for bone density is weight-bearing or higher impact exercise that really promotes the formation of new bone. So weight-bearing exercise stimulates osteoblasts, so the builder cells. So walking upstairs, hiking up mountains, anything that has you on your feet with resistance against a good amount of gravity will help. And there were studies that have been done in older men and women who performed weight-bearing exercise, and they actually showed increases of bone mineral density and bone strength and bone size. as well as reductions in markers of bone turnover and inflammation. There was one study where 22 months of weight-bearing exercise increased the lumbar density by 6.1% in an elderly study group, so meaning above the age of 80. So if you're not strong enough for this kind of activity, you can always consider starting small, like with a weighted vest even, and walking, and just slowly adding weight to it over time. You can easily get a weighted vest nowadays, and they really do have a measurable impact on bone density if they're used regularly. Actually, just as much really as if you used a drug therapy, so long as the other components that we're talking about today are at least paid attention to. So what your diet is like, which drugs that you're on, and other factors that we're going to talk about right now. Now, one of the things that often is confusing for people is when they get a bone exam back, like a DEXA scan back, and their hips are looking terrible, but their spine's looking great, or the spine's looking terrible and the hips are looking great. And I've seen quite a few where there's probably a simple reason. It's probably postural. So in a skeleton, you have to load the forces correctly. And so this diagram, I just have this little diagram here that's just showing what you should basically have in alignment. So you should really have like your head on top of, the base of your neck, and your pelvis and your knees and your ankles. They should all really be in alignment with each other. But I'm sure you've seen other people where it's really, really obvious and they don't have a great posture. And you might even be a victim of that yourself. People who tend to sit hunched or who have exaggerated curves, either rounded or sometimes too straight and are creating problems in the rest of the spine. Or maybe, you have a condition like scoliosis where the bones are not sitting in that right gravity-dependent structure. And when you have that, the forces that are gravitational forces that are going through bone are not going to be centered in the places where you want them to be. So if you have a postural problem, sometimes you just need a great chiro or maybe some physio and massage to just get things reorganized. There are lots of chiros that will do postural assessments for you and actually help you to do a picture just like this one and gauge it over time. Sometimes physios will do this as well. But I think it's an underappreciated reason for bone densities of varying weakness and strengths on a DEXA. So if you have had this problem, you might just want to reevaluate your posture. Now, chronic low-level inflammation is probably one of the most important factors in bone loss. So dietary changes to something that's more anti-inflammatory for you will decrease bone loss. Even if you are already having a lower bone density, you can make some changes to that and improve it. So the inflammatory illnesses that are often associated with an increase in osteoporosis, so that's where you're losing enough bone to create an increased fracture risk, are notably rheumatoid arthritis, not osteoarthritis, incidentally. So if you don't know what kind of arthritis you have, make sure that you're clear on that. Rheumatoid arthritis is the autoimmune version that you get bony destruction with. Osteoarthritis often is the spurring kind, where you might have inflammation, but you're not usually destroying bones. Excuse me. Must be true. That's what my grandmother said. If you sneeze after you say something, it's true. It's a wonder I don't sneeze after everything I say. Just kidding. Also, lupus is an inflammatory disease where you have more osteoporosis. Irritable bowel syndromes like irritable bowel disease, celiac, cystic fibrosis, chronic obstructive pulmonary disease. Some of this may also be aggravated by glucocorticoid use because often you're using those agents within those disease management protocols. But even in people who haven't used glucocorticoids, you're going to see a change in bone density with these conditions. So if any of those apply to you, improving inflammatory control will really help prevent bone loss. And it's so important, again, to understand these conditions have impacts on many different tissues. And now that you've had the chance to see the inside of a bone and just how much stuff there is in there, it should make more sense, I think. Healthy fats are also important to bone. Having enough omega-3 fatty acids has been shown to help protect against bone loss during the aging process. That's going to be particularly true if you are from Northern European climates genetically. So the English and the Scots and the Irish and the Norwegians, all those people really have to pay attention to how much omega-3. They're just designed for more. If you're Mediterranean, of course, you're going to still get omega-3s there. You can tolerate a different ratio of those. So if you don't like fish, you can always increase, your omega-3s with flax or walnut or chia seeds, whatever suits your diet particularly. But it's actually a fairly important thing. And again, this is another piece that we see almost all the time. We keep coming back to what is the balance between the things that we tend to eat the most as Canadians and the things that we tend to be a little iffy about. Now, of course, hormones matter to bone density. And I don't want to negate that. But I'll tell you that probably one of the most important hormones that you have to pay attention to in terms of bone mineral density is stress hormones, in particular cortisol. Now, remember how I just said glucocorticoids, where if you apply them in high amounts, you really affect bone density? Well, cortisol is a glucocorticoid. It's the one that one of the ones that you produce naturally inside, and you produce that in response to stress. And so what cortisol actually does is it indirectly acts on the bone by blocking calcium absorption, and it increases bone resorption and ultimately will reduce bone mineral density. Even a short bout of elevated cortisol secretion can cause a decrease in the readings of your bone mineral density. So this is true in men and women. You can especially see it in male athletes like cyclists who don't do as much weight-dependent activity and training. They're always on a bike, right? So it's a different kind of exercise that is not as gravity-dependent for the most part. I'm sure, like if you do a lot of biking up and down mountains, it probably improves it somewhat. But on average, male cyclists will have decreased bone mineral density because of this. A lot of male cyclists are also a little bit smaller people because they just make better cyclists. So that probably also doesn't help. And androgens and estrogens. So androgens are things like testosterone. Estrogens are all the kinds of estrogens that apply both to males and females, are both involved in increasing bone mass in men and women. So it's obviously not precisely the same way in both genders, but balance in the hormone picture is really important. And so much of that kind of loss can be done way before you ever know about it, especially in terms of the stressors. And I also want to make a plug for progesterone here, because again, more recently, it's become more clear that progesterone can be very important for the prevention and treatment of osteoporosis. And remember how I just said Depo-Provera creates a problem with bone density? That is a fake progesterone. So it actually prevents you from ovulating and making your own progesterone as a woman. And it turns out that balance between progesterone and estradiol, which is the main estrogen, is really crucial to get a balance between those to create better bone regulation. And you and I, any of you and I, may have talked about progesterone in terms of health long-term, or in terms of perimenopausal balance, or sometimes in terms of balance where the stress has been really high for a person. Like, you'll actually find that progesterone is the physiological partner of estrogen. It's basically collaborating with estradiol in every cell, in every tissue. So it's particularly involved in building new bone. So if your menstrual cycle is normal length and you have normal ovulations, you have these two things in balance, and the bone density is stable. But if people start to have anovulatory cycles or short luteal phases, so that's that second phase of the cycle, or low, in general, low progesterone levels, that basically is going to have an impact on bone mineral density. Now, it's considered that in women, bone density is decreasing dramatically at menopause because estrogen levels are decreasing. But again, you're going to see prolonged absence of menstruation sometimes in women before such a dramatic change takes place. And it looks like it's just estrogen, but it isn't just estrogen. It's the effect of all of it. In men, low testosterone levels can cause a loss of bone mass, and there are certain conditions where testosterone is low, where you'll see that more markedly. So you can actually test hormone levels and determine the best course of action to take if your levels are too low relative to your time in life. And of course, you need to still have some, regardless of how old you are or how young you are. We definitely see those sort of things coming way earlier, I think, personally. Now, I just wanted to make a little bit of information about tests for bones. So you should always take assessments in alignment with your personal situation. So if you've already had a fracture with an injury and it's your first fracture and it was some very, very minor injury and you start to get a fracture, that's a whole different category that we're already starting to see maybe that your bone density is not good. It can also just be an unlucky break, honestly. DEXAs have limitation. They're not reliable if you have significant osteoarthritis or rheumatoid arthritis or scoliosis. And like I said, for posture can have a big impact on what that ends up looking like. They're basically a type of X-ray, and they can't always identify the true fracture risk. They're technically the most accurate in the femoral neck, so what's known as the hip when you get the DEXA. And if you have a report in front of you, the difference between a T-score and a Z-score, so the T-score is comparing your bone density to a healthy young woman, which sometimes is not really a fair comparison, just so we're clear. And especially if we're not comparing it to what you were like as a young woman. I think it's actually a mistake for us to do DEXAs after the fact and, like when you're perimenopausal, instead of, doing one at the time of life where you technically should have the most bone mineral density. I think most people would not panic if they realize that they're always kind of at a certain percentage from the time that they were, 30. That doesn't mean that, having a T-score that's, the scores are reported by standard deviations. So under a normal curve, you have about 2 standard deviations that cover about 90% of your data. That means that if you are at minus 2.0 or more, that you technically have lower bone density than 90% of the population. But again, we also need to know when that bone loss occurred. So Z-scores, sorry, I'll just finish this thought, but Z-scores are comparing you to people your own age. So a score of 0 is average, technically. A DEXA has to change by at least 3% to be obvious, or like to result in a change of the level on the calculation. And you may have heard that it's really important to use the same machine and ideally to use the same technician because you want consistency in how it's measured because of the errors that are inherent in a DEXA scan. There's other ways, though, to assess the bone that are laboratory test oriented. You can do what's called an N-telopeptide test or a C-telopeptide test. These are kind of just 2 measures of bone collagen being broken down and being secreted. So part of this is obviously normal. Like you're going to always be breaking down bone and secreting bone proteins. But if your N-telopeptide is high now, what that tells you is right now there's more than average bone collagen being secreted. So sometimes that can be because you've just taken a big dose of glucocorticoids or you had to be on antibiotics for an extended period of time. If you have a low DEXA and your N-telopeptide is normal, what that says is that loss occurred not right now. It occurred sometime in the past. And this is, again, part of the problem is mapping out when precisely did this actually happen. There's also a couple of other things that you can test. You can test osteocalcin. So that's that hormone that's produced by osteoblasts when they're building bone, and it's vitamin K dependent. So if you measure that and it's low, sometimes it can be because you just don't have enough vitamin K. Or it can be that for whatever reason, you're not building bone as quickly. Again, these are important ways of reassessing the situation instead of immediately putting you on a drug. You also can test bone-specific alkaline phosphatase. So that will detect early breakdown. Usually, though, we use that to see if you're being over-medicated with bisphosphate medicines. So like Fosamax and the other medicines that are changing by force how bone turnover is happening. The unfortunate problem with a lot of those drugs is that they sometimes will improve the DEXA look, not always, but sometimes, but they don't really improve the health of the bone. So I would consider those things to be like a last-ditch effort when the bone mineral density is really creating a problem, like where you're really seeing your fracture risk increase or you're already losing height. To a degree, some of that is normal, again, just to be clear, but when we're talking about more than average loss of height. So I think you're starting to, again, see a bit of a theme here. We've talked about many things that are related to many of the aspects of health that we've been examining over the last 2 years with these lectures, and this one is no different. So I'm hoping that gave you a bunch of good information. And I just want to remind you that we are going to continue to do our monthly series. Thanks for coming, and I'll see you next time. Thanks for watching. I love to connect to my patient community to inform and inspire, and I hope you'll join us again in the near future. Don't forget to check out whole-life-medicine.com for more webinars and events.